Hello, my name is Aoife. I'm one of the podiatrists in the foot and ankle team based here at ROH. Today I'll be doing a demonstration of the foot and ankle examination aimed for medical students. I'll cover the basic examination principles of look, feel, move and special tests. And I'll also mention a few common pathologies of the foot and ankle. This is Jules, a colleague who's kindly volunteered. Before you start, introduce yourself and gain consent from your patient. Hello Jules, my name is Aoife. Could I examine your foot and ankle today? Are you in any pain anywhere? Excellent. So the foot and ankle should be examined in walking, standing and sitting. Exposure should at least be above the knee, and always check the affected side with the unaffected side. Let's start off with gait. Jules, would you mind walking up and down the room for me? Observe the patient gait. Observing for the 3 rockers of gait, the first rocker is the heel rocker, which occurs at the heel strike. The second rocker is the ankle rocker, which occurs at mid-stance or the foot flat. And the third rocker is the forefoot rocker, which occurs at the toe off or the push-off phase. Observe for any abnormalities, any missing rockers, any leg length discrepancies. An example of a normal gait is an antalgic gait. This is when your patient walks with a limb secondary to a foot pain and the stance is shortened relative to their swing phase. You will now assess the patient walking on their tiptoes. Jules, would you mind walking your tiptoes to the end of the room? Observe their plantar flexors myotomes S1 and S2. And Jules, on your way back to me, can you walk on your heels? Observe for their dorsiflexors myotomes L4 and L5. If the patient is unable to perform these movements, or they struggle to do so, could indicate a joint tendon pathology or neurological problems. Your general inspection should also include assessing your patient's footwear, looking out for any abnormal wear pattern, as this will give you clues to the plantar distribution. Also check inside their shoes for any insoles or orthosis devices. Look around the room to see if they're using any mobility aid or ankle foot orthoses. And if you do have a prescription list for their medications, be sure to check on that as well. So you will now examine your patient in standing. Have your patient stand in relaxed calcaneal stance position. This is when they are in relaxed standing with their feet in the angle and base of gait. You would assess the patient from the front, the side and the back, and also take note of any misalignments or abnormalities of the knees, hips and back, as their feet can be affected by these. I will now assess Jules from behind. Jules, are you all right to turn around for us? Thank you. Assess for lower limb swelling. Is it unilateral or bilateral, localized or diffuse swelling, as this will give you clues to the underlying cause. For example, localized unilateral swelling could be a tendon or a joint pathology, as opposed to bilateral swelling that could be due to an underlying medical systemic condition such as cardiac renal issues. And in this position as well, you can assess and look at the calf muscle bulk, any calf wastage, and also check for Achilles tendon for any swelling, thickening, erythema or discontinuity. So in this position, you can also assess the foot posture alignment, the frontal plane of the hind foot, for example, looking out for any valgus angulation, varus, or is it a fairly neutral hind foot alignment. You can also assess the transverse plane of the foot, laterally looking for too many toe sign where more than 2 toes are visible laterally, or is there more toes visible medially towards the midline. And standing from the side, Jules, are you all right to turn around for me and bring one foot out? The other side, sorry. And in this position, assess for the sagittal plane of the foot, looking at the congruence of the medial longitudinal arch. Is it well formed, or is it too high to indicate a pes cavus foot, or too low to indicate a pes planus foot? That's fine, thank you. You will also assess your patient from the front, assessing for any deformities or misalignment of both feet and the ankles. A common forefoot deformity is called a hallux valgus, or otherwise known as bunion. This is when the first metatarsal deviates medially towards the midline and the hallux deviates laterally towards the lesser toe. Lesser toe deformities are quite common as well. We'll now assess the patient in non-weight bearing. Have the patient sit on the couch. Prior to this, I've already washed my hands and gloved up. So in the look aspect of the examination, look for any abnormalities of the lower limb, such as swelling, erythema, bruising, scars, rheumatoid nodules, any ulcerations in between the toes, or psoriatic plaques. You would also then check for plantar or dorsal callosities and look at the nails for any psoriatic changes, and look for any forefoot deformities, which can also be seen in non-weight bearing. In the field aspect of the examination, I would firstly check the lower limb temperature using the back of my hand. Start proximately and go distally, feeling out for any localized hot spots or warmth. Next, I'll palpate the pulses. Dorsalis pedis is located just lateral to the extensor hallucis longus and around the second and third cuneiform here, and the posterior tibial artery, which is located just posterior to the medial malleolus. You'd also check for light touch sensation, dorsally for superficial peroneal nerve, in the first web space for deep peroneal nerve, medially for saphenous nerve, and laterally for sural nerve, and plantarly for tibial nerve. You feel that all normal? Good. Next, you will palpate the bony structures. If you are trying to rule a fracture out, then in line with the Ottawa ankle rules, you'll be palpating the tip of both malleoli. From the tip, palpate 6 centimeters approximately. You'll also palpate the navicular bone and the base of the fifth metatarsal. And of course, if you're trying to rule a fracture out, another criteria is to ask your patient to walk 4 consecutive steps. Other bony structures include talus, calcaneus, cuboid, the 3 cuneiforms, metatarsals, including the heads, and the phalanges. Next, you will palpate the joint lines, the ankle joint line here, the subtalar joint medially and laterally, the mid-tarsal joints, which is consisting of the tilionavicular joint, as well as the calcaneocuboidal joints, tarsal metatarsal joints, and your metatarsal phalangeal joints. Assess the IPJs as well, which stands for interphalangeal joints. We'll now assess the tendon. So I'll assess some of the key tendon structures. Tibialis anterior tendon. For better visibility, you can ask your patient to dorsiflex your foot. Are you all right to bring your foot upwards? And then palpate the tendon there for any pain. And relax your foot. Check for the tibialis posterior tendon and into its insertion. And laterally, check the peroneal tendons. We'll now assess the ligament structures. Laterally, you have the anterior talofibular ligament here, inferior and anterior to the lateral malleolus, or ATFL for short. The calcaneofibular ligament, or CFL, is located just inferior to the lateral malleolus here. And the posterior talofibular ligament, which is posterior to the lateral malleolus here. And for demonstration, I'll use this foot. You can palpate medially the deltoid ligaments located here. And don't forget to palpate the plantar fascia tissue as well, which is located underneath, on the heel. So you would palpate the origin, which is around the plantar medial tubercle calcaneum, and you palpate distally into their insertion on the bases of the toes, feeling for any thickening or any lumps which might be plantar fibromas. We'll now proceed to the move aspect of the examination. I'll start off with active range of motion. This is where your patient will do the movement. We'll check for ankle dorsiflexion. Jules, can you bring your feet towards your face? Ankle plantar flexion. Can you bring your feet down as if you're going on tiptoes? Foot and ankle inversion. Jules, can you bring the soles of your feet together? Eversion brings your soles outwards. Perfect, and relax. Check for toes flexion. Curl your toes down for me as much as you can. Toes extension. Bring your toes up towards your face. That's perfect. We'll now check for passive range of motion, looking for limited movement, crepitus and pain. We'll start with ankle dorsiflexion and plantar flexion. Inversion and eversion movement at the subtalar joint. So you want to lock the talus into the ankle mortise and move the heel inwards and outwards. Check for mid-tarsal joint movement. Cup the heel, grasp the forefoot and midfoot, invert, evert, adduct and abduct the joints. Check the metatarsal phalangeal joints as well, beginning with the first MTP joint, dorsiflexion, plantar flexion. And do the same for the second, dorsiflexion, plantar flexion, and so forth. Check the IPJs as well. Distal phalangeal joint, plantar flexion, dorsiflexion, and the proximal interphalangeal joint, plantar flexion. We'll now check for resisted range of motion, assessing for the tendon function and pain. Check tibialis anterior tendon, asking your patient to dorsiflex and invert their foot. Jules, would you mind bringing your foot and ankle towards my finger here and keep it in that position? Add resistance. Jules, do not let me push you downwards. Well done. Check for tibialis posterior tendon by asking your patient to plantar flex and invert their foot. Jules, would you mind pointing your foot towards my finger here? Perfect. Hold it in that position and do not let me push you outwards. Well done. And checking for peroneal tendons, I use this foot to demonstrate. Get your patient to dorsiflex and invert their foot. Jules, can you bring your foot? Perfect. And do not let me push you inwards. Wonderful. You can also add the double leg and single leg heel raise tests to test for the function of the tibialis posterior tendon. So for this, you get your patient to stand in front of the wall where they can hold on to the wall if needed, and you get them to firstly do tiptoes on both feet. Would it be okay to go on your tiptoes? Perfect. And what you're looking for is arch restoration here, inversion of the calcaneus, and the ability of the patient to do so. And you can rest your feet down. And next we'll check for a single leg heel raise test. If you pop one foot up, perfect. And go on your tiptoes again. Again, looking for the same thing around the arch and the inversion of the heel and the ability to perform the test. Thank you. I'll now demonstrate a few special tests. Let's start with checking the integrity of the lateral ligaments. To do this, you can perform the anterior drawer test by pushing down the tibia in this direction, cupping the heel, and then draw it anteriorly towards you. And what you're feeling for is any laxity, any pain, and check the end firm feel and compare it with the contralateral side. To test for a high ankle sprain, you can do the syndesmosis squeeze test, where you're squeezing the tibia and the fibula from proximal, work your way down. And the test is positive if the patient complains of pain. I now perform a special test to test for arthritis of the first MTP joint. It's called an axial grind test, and this is where you compress the articular surfaces of the first MTP joint and make small circular movement. The test is positive if there's pain reproduced. I'll show you a different test now for synovitis of the MTP joint, neuroma or intermetatarsal bursitis. It's called an MTP joint squeeze test. The test is positive if you feel a Mulder's click or if there's pain. And you can also do the test and palpate in between the web space for pain. The most common site for a neuroma is in the third web space, and it's called the Morton's neuroma. We'll now do a special test to rule out rupture of the Achilles tendon, And what you do is you get your patient to kneel both knees on the chair with their legs hanging. And you would squeeze the calf. The test is positive if the foot does not plantar flex. And that concludes the examination. Thank you, Jules.
Thank you, Aoife.